Hello, I'm Jana Martin, Chief Executive Officer of the American Insurance Trust, known to most of you simply as the Trust. We're delighted that you're able to join us virtually today for this next webinar in our virtual webinar series. The Trust is pleased to be able to offer this informative content free of charge to our policyholders. The Trust is pleased to once again partner with Drs. Margot Adams Larson and Sarah Smucker Barnwell to present these telehealth community chats. In the interest of time, we've placed their bios on a slide for you. Finally, this virtual webinar will earn you 1 CE credit. This can be combined with 5 other Trust continuing education credits to save up to 15% on your Trust-sponsored professional liability insurance policy. Again, I hope everyone learns a lot over the next hour. Please join me in welcoming our esteemed presenters.
Well, thank you, Dr. Martin. So excited to be here today. I'm Margot Adams Larson, and Sarah, I'm just so thrilled that we could get on and chat again. Welcome.
Thanks, Margot. I'm delighted to be here, and thank you to Dr. Martin and the Trust team for having us once again.
Just by way of quick disclosure before we get going, Sarah and I are both very much telehealth enthusiasts. We do an awful lot of training and presentations regarding the topics, and certainly the things that we'll chat about today are often our opinion, and we try and share a variety of other people's perspectives as well, but this shouldn't be taken as anything specific to the Trust, but also just information for you to take in and find your own perspectives on as well. We also are very avid enthusiasts for the Trust risk managers that we have sometimes on our advocate speed dial that always we encourage folks to call them to really talk through the very specific particular details that might pertain to their situation. Finally, our last disclosure is we are using technology. And while we're getting smooth and getting in the groove of the presentation, doing this in webinar form, inevitably, as soon as we start talking about technology, something, according to Murphy's Law, is likely to fail. And we'll go with the flow. So we just kind of put that out there.
Talking about it.
Exactly, exactly. I'll turn it over to you, Sarah.
Sure. So I always like to take a moment to describe what these telehealth community chats are. This has been a bi-monthly check-in. So we've been doing these about every 2 weeks. And one note is that moving forward, as all of our telehealth practices mature, we're going to take this to about once a month. So we'll be meeting again in about a month. This is a forum in which we can talk about some of the practical how-to information in telepsychology. We have a strong emphasis on figuring out how to navigate these practical aspects with, the ethics code in our heart. So really finding our path to ethical telehealth. Traditionally, we have tried to answer your questions live. We do our very best. We'll be receiving those through the Q&A box, and we'll be stopping several times, interspersing questions that were submitted from the previous week with new questions that emerged today. And if we don't get to your questions, please know that we review those Q&A logs for future sessions. And I'll point your attention down to the bottom of your screen there, where you see an email for telehealthcommunity@trustinsurance.com. This is an email that Margot and I both receive and offers an opportunity for, if you're like me, you have a question, as soon as the webinar ends, you think of what you wanted to ask. Please don't hesitate to send it to us. We'll do our best to respond. And if we think it's a question that others might share, we'll incorporate that content as best we can to our next telehealth community chat. So I think, a theme of today will be maturity, the maturity of our telehealth practices. And if we look at the agenda on the next slide, we can kind of see some of the themes we're going to talk about today. And when I say next slide, I mean the resource slide. We do have, and we will show again, a slide that offers resources that we think will be relevant for telehealth. Margot, do you mind going back one and we'll take a look at it?
Sure, we can go back.
Thanks.
Do you want me to talk a little bit about it?
Sure thing.
Okay. This one you've seen before. It's not new, but if you're new to the telehealth community chat, it'll be new to you. It just lists out a number of links to get you to some of the top information that we have referenced either in some of our past chats or that we may reference today in this one. And just making sure that we're getting you the links for that information. So those will be available. If you're interested now, you can go back to some of the older chats and pull it out. Otherwise, we'll have it again at the end. So on to the agenda.
Yeah, we have a full agenda today.
We do.
And I really feel like I think this is an exciting chat. I think, we're moving on in many ways to themes that emerge as our telehealth practices mature. For many of us, the role of telehealth in our practices will be marathons, not sprints. And so, we want to think through some of the themes that in the early days of adopting telehealth, either into our practices or more prominently into our practices in response to the global pandemic. In early days, I think a lot of our concerns were centered on the moment right in front of us. How do I get these clients to receive regular care? How do I work out billing and informed consent and payments and some of these practical aspects? Now I feel like we're looking into the future and thinking about, what does this mean for the profession? What does this mean for training? What does this mean for the maturity of our practice as we move forward? So as such, we're going to talk about themes today of clinical supervision, both of trainees and then collegial consultation as well. We're going to talk about office space in a post-pandemic world and its role in telehealth. This was inspired by a great question we had last time. We wanted to expand even further on. We're going to be talking about what we might call a mixed model practice. How can we think about our practices not as being either in-person or telehealth, but really in the long run, think about what telehealth as a tool of, diverse ways we can be seeing clients, how are we going to use this? And thinking about telehealth in inpatient care contexts. And then as always, we're going to stop.
We have a lot to cover, and Sarah, I just want to let you know I'm getting a little bit of jittery stuff from your side, so I'm not sure if I'm coming across that way as well, but just so that others who are on live know we recognize there's something going on, but just like we said before, we just keep on plowing ahead. So I'm really curious, Sarah, some of the questions we've had regarding supervision. And as you said, people in just practice, we kind of pivoted immediately and took care of the emergent needs at that moment, and not necessarily emergent in terms of clinical emergencies, but just the current clients and what their needs were. And now we're really seeing, as we're broadening out, okay, now we have to figure out what's going to happen with training. And I think part of these chats is helping us elevate our professional thinking level in terms of what we're doing with regard to how we're managing through all of the nuances of changing laws and changing requirements and all of that. And the biggest one that I see coming down the pike is really what's coming in terms of both the university setting as well as the clinical training settings. And so I know you've had some ideas and done some reading and conversations about that. So I'm eager to hear.
Yes. And Margot, can I check in? How is the audio now?
Great. It's pretty good now.
Wave vigorously at me if it changes. Okay. I think a lot of trainees, are in a position wherein they are trying to figure out what this means. They've been in the middle of their training program, and I'm referring both to the trainees that will be, it's July already, soon concluding their year's training, as well as those with the upcoming training cycle. So I think we need to be thoughtful about these folks because they're really kind of caught in the middle. I look to our sort of industry leaders. The American Psychological Association has explicitly published, I think, some really great information for supervisors and trainees, and specifically recommending that they think about the role of telepsychology and telesupervision in ensuring that training can continue. I was going to say as usual, but that's not quite right. But can continue, with the usual accrual of hours and the usual level of didactics. One thing of note, and this is something that I think is just an evolving question, is, we know that the American Psychological Association Office Committee, on Accreditation has given us guidance regarding what percentage of supervision can be remote versus in person. And this varies for folks who are a pre-doctoral level trainee, a postdoctoral level trainee, so forth. Now, on the APA website, it does suggest that programs who have questions about this contact Committee on Accreditation. And actually, I've reached out as well, and I'll share what I learned. So I think this is going to be an evolving area of practice. And as soon as I learn more, I'll be happy to share it in this forum. But, I think that there is this need, this understanding that this may need to be expanded the longer the global pandemic goes on. So the longer we have these concerns, it seems more probable that we're going to have to be thoughtful about having telesupervision be a way that we're supervising supervising our trainees, in the long run. And so I think there are, though, these unique opportunities in the telesupervision format. And actually, I had the great pleasure of writing on this topic with Dr. Steve McCutcheon, who is just wonderful and a kind of guru in all things training. And, one of the things he and I spoke a great deal about was the manner in which, when you do supervision about telehealth, there's something to it about doing it in the telehealth milieu. When I think of trainees, I used to oversee a postdoctoral fellowship in telehealth and rural outreach. And in those moments, we required that a portion of the supervision be conducted remotely because we wanted the student to have the opportunity to learn in this environment. We didn't want them always wearing the therapist hat in the telehealth milieu. We wanted them having conversations that were potentially difficult. We wanted them having emotional moments. We wanted them to work on themes of how do you disclose when something's hard? And this doesn't always happen in supervision, but I think in good supervision, it sometimes does. Mm-hmm. And so I think there's a nice parallel to be had, your ability to show, your affect and your expressiveness on camera. I've shared in this forum before that the first thing I did when I had a new telehealth trainee was record them and show them not recording. And people were often surprised. And I was surprised too, because someone who's absolutely warm in person could read stone cold over telehealth, and helping them understand how they could translate some of the cues that they were giving in person into the modality. That ability for them to just develop rapport, to demonstrate indicia of that rapport, and, having them engage in some behavioral observation through role play. So I think it's a really nice opportunity for supervisor and supervisee to, as we said in this forum before, you can talk about the gaze issue until you're blue in the face, but if you describe to someone what it's like to look in the camera versus what it's like to look down on the screen, there's really no proxy for showing someone. I think so too in telesupervision. It offers this unique opportunity for us to provide our students with specific examples of what they may face in the modality.
It's interesting, Sarah, because I'm remembering back to grad school and we had to videotape, right? At times, the old-fashioned, like we had like video cameras
Yeah.
for the new folks on the call, and it's interesting because there definitely was, I would say, some apprehension of doing that videotaping and then having your peers observe your session, and that was part of our supervision model. And there's a recording aspect now in terms of some of the things that is still, I think, required of observation, but other people can be watching live while you're seeing your clients as well. I think the technology has advanced itself to a place where a lot of therapists and trainee therapists are in a position where they could do a lot of practice where the patient might not even actually be there. The way the device records allows them to rehearse a lot more of the camera effects than it really would come across in kind of having a video camera recording. So I
Right.
was just kind of thinking back to those days as you were describing that. Is there any particular guidance that they've given about recording of sessions, particularly in the telehealth level?
I am not explicit to formal guidance in as much as recommended best practices. I can tell you from listservs and discussions I've had the good fortune of participating in, a few themes have emerged. One, some training programs are using, video conferencing a lot like bug in the ear. I don't know, back in the days where you had the little listening device and you were behind the one-way glass and someone with a microphone was telling you what to do differently. Functionally, it has been conducted such that, the supervisor is actually attending the session with the video turned off, and they're using the chat function to make their recommendation. I have heard of this model. I think that sounds like a lot to balance cognitively. I think, Margot, you and I do these webinars, and I think even, oh, we're so big now. Even, even reading the questions while you're speaking can be a little disorienting, and I think that for people who are in the middle of a therapeutic intervention, that can be challenging. So more often, I have heard of people doing what you are describing, which is recording the session for later review. And the thing I would just mention here that is often discussed is the same rules apply. So just as when we have a client come into a clinic and we're going to have the session recorded and later reviewed by a supervisor, there is a more involved informed consent process that makes them aware of that recording, that makes them aware of how that information will be handled, how long it will be stored and so forth, and that they consent to that and they know who will have access to it. I think it's important here to, again, beat the drum of product design for healthcare. Because if you get the Zoom product, let's just pick on Zoom because we're using it today. If you get the Zoom product that is for telehealth, it's very nice, very fancy, a little bit pricey, then you will have certain features disabled. They actually disable cloud recording. And I think it's for the explicit purpose of if you recorded a therapy session that needs to be saved remotely and not often to the cloud somewhere, unless you have a very explicitly stated agreement with the company that's doing the cloud storage that they will treat this in a way that is conducive with HIPAA.
I think you raised a really important point, Sarah, and that's about the consent process. And, we've talked a lot about documentation and about making sure that our patients are informed, and equally important to make sure all the paperwork that we've talked about from a therapist patient perspective translates into that training atmosphere and arena in terms of any type of clinical supervision. And I think most of the graduate programs are really in tune with these aspects. I think some of the pieces that's made it especially difficult at the moment is students have scattered, their patients have scattered, and so we're really in many, many jurisdictions potentially in managing all of the, can we do this? How is it going to work? Who's, is it going to count for my training hours, for my licensure hours, et cetera? And it just really takes more time for that due diligence to really go through and make sure all the T's are crossed and I's are dotted, and everybody in that lineup is really understanding that process well.
That's a great point.
So, were there other areas or things that you've noticed in terms of collegial supervision that have come to mind during this time?
Yes, I think so too. The similar considerations would apply to consultation. So, in my professional life, I provide consultation and telehealth. And I have to say, even when I could have met with people in person, I actually, unless they prefer otherwise, prefer to do it over video conferencing, because I think it offers this opportunity to talk about the milieu that actually will benefit the consultation more over video than if I was sitting next to you trying to describe why it's problematic to be a hands talker versus showing you on the video. It's a different phenomenon. And so also I think again, our recording, we want to be really thoughtful. If we do that, we need permissions. I think fewer people are recording consultations, though I've had people ask to record a consultation we've done. And in those instances, we think through, well, how are they going to use the recording? And, do we really want a bunch of recordings hanging out there of, collegial conversations we have? So I think there are similar considerations. In some ways, it feels like slightly lower stakes poker because, the interjurisdictional considerations are not as prominent because, obviously you can speak to a colleague across jurisdiction. But, the issues regarding recording and the use of the milieu still feel relevant.
Sure. And I think too, it's always worth saying, even though you might not be recording on the platform, that doesn't mean that they may not be recording on their device and or other ways of recording from a device. So it kind of segues into some of the conversations we've had about remote testing, and we can refer folks back to previous chats to find some topics on that.
Well, Margot, I spent this weekend in my Seattle office with a tape measure, checking how far apart certain chairs and couches were. So I'm excited to ask you some questions about office space in a post-COVID world.
Well, I too spent some time thinking through the new concepts of office space in post-COVID. And I think a lot of universities are actually spending time doing just what you did, Sarah, and that is measuring their lecture bowls and lab space and clinical space to really realize that 6 feet apart and how many people can fit in that. And we all wish we paid more attention to 7th grade math so we could compute that really easily. But one thing that I'll start off my segment here with is it's super important to connect with your public health department locally because in many jurisdictions from a state standpoint, they are issuing state-based requirements in terms of getting back the smart return to work or return to in-person whatever. But sometimes in areas where there's higher local viral folks or an outbreak, those local jurisdictions may actually have some different types of established requirements. And a great example this week, Chicago issued some travel ban advisories that impact the city of Chicago that don't necessarily impact the rest of Illinois. So there are things, it's not as easy as just kind of contacting the board office and then contacting, the state public health department. You really need to be looking really closely to where your office is located. And so we'll use the terminology for 6 feet, but it may actually be 10 feet, or it might be a different amount of people that are allowed in that space. You really have to look to your local area to find the numbers involved. I think one of the biggest questions we've had is, what if 6 feet isn't possible? There are a lot of offices that are much tinier. So what are folks doing? There's a whole other side of this, and that is, are you gowning up and putting on the hazmat suit and having your sessions? Are you investing in, polyglass so that you can still, sit on one side of a desk and your patient can be on the other? There's a number of different approaches and ways that folks are looking at being creative with this. It's not just the 6 feet possibility, it's also ventilation. It is also, the sanitization of the space. It may also have to do with the type of patient population that you're working with. I know a number of colleagues that work in populations specific to geriatrics that, you know, their entire caseload is at high risk. And so that really has resulted in maybe clinics opening, but not opening for certain patient populations as well. So when that 6 feet isn't possible, there's really a lot of other areas and aspects and factors that you have to consider. How can you be safe? Is it possible to be safe? How much personal protective gear do you have? How much of that do you require your patients to utilize? You know, where is your state in that return to in-person service? And you know, are you needing to have a thermometer to check people's temperatures? Are they doing that in the parking lot?
I was really excited to see that American Psychological Association had announced their communication and negotiation with Amazon to facilitate psychologists getting PPE. I thought that was great to have us treated like the medical professionals we are. And so I would encourage anyone who, if you haven't heard of this, to check out the APA website, or just send a Google out to APA Amazon PPE. It gives specific instructions about how we can order that, which I thought was very helpful.
And truly, in some areas, some of those, some of the gear is still very difficult to get. So if that's something that is challenging, certainly reach out for that. You know, there's a number of areas of practice that folks have really had a lot of questions about, in particular assessments, and folks that, you know, utilize assessment tools that require manipulating objects, paper and pencils that you have to exchange back and forth, pointing to things in books. You know, certainly we've managed to be creative about some of these things. Previously, we've managed to do assessments in ICU units for patients with certain particular needs and protocols. And it's not that it can't be done, but we definitely need to think about how are we able to do this, you know, with making sure that we're able to sanitize well the tools that we're using and the space that we have to do the assessments within.
Yeah.
You know, go ahead.
Oh, I was just going to say we've received some great questions, and at some point, I'd love to read some to you.
All right. Let me mention one more item on this, and then let's move on to some questions.
Okay.
So I think one of the big questions that keeps coming up in a lot of the listservs that I see, and some of the questions we've had come in, and that's, what if insurance is requiring services to be in person? And, you know, obviously we've got a lot of changing, expiring executive orders that now insurance companies are perhaps responding to, not having to pay for services or treating them in an equal manner. And it really comes down to calling the insurance company and working with them regarding each particular case as it may transpire. And, you know, if it's your practice and related to you as a professional and not being able to come into the office because you may be in a high risk category, then it really is incumbent upon us to kind of connect with the third party carriers to figure out how and we may be proceeding with both the care and or referrals that we may need to be making during these times. And while that's not optimal, that may be some of the things we have to consider.
That's a great point.
Awesome. What questions have come in?
We have lots. And a few of our themes were actually, we received a question about inpatient care, and then we also received a question about what platforms we use. And there are topics we're going to talk about in a little bit, so I'm going to read some of the other ones.
Awesome.
And this one, I want to acknowledge, I may not have the perfect answer for, but I feel for them. And so it says, you know, what do you recommend for patients who refuse both teletherapy and in-office visits? And at first it made me go, oh, but that's a situation I can imagine a lot of folks in, because not everyone wants telehealth. And you may, for various reasons, for your health, your client's health, or what's going on within your jurisdictions, you know, lockdown orders, not be able to be meeting in person. And so what can we do for those clients? I think, go ahead.
That's an awesome question. It does kind of bring up some of the, I guess, ideas about what if this weren't a COVID scenario, what would we do for somebody that perhaps wants therapy but doesn't want to come into the office, and be thinking through some other models of care, maybe some self-help models of care, maybe resources and tools to kind of give them some guidance as to things they could try on their own, that, if they find success with that, then perhaps they don't need something that's more well defined in terms of the office setting. And then maybe it's really kind of working through some telephone calls or other creative approaches to help them become maybe more comfortable with what might be a stepped care approach.
My mind goes in the same way. I mean, it divides. On one hand, I'd want to know why, why don't they want to do the telehealth? It's a totally valid thing to decline. And I'd want to know why. Are they absolutely convinced they could never, ever like it, but they've never tried it? It's like in my house, you have to take a no thank you bite of things. You don't have to take a no thank you bite of telehealth, but I would be curious if they have never tried it. Could I speak to some of their concerns? Are they just so concerned about information security? Could I address some of those concerns? So I don't know all the answers, but I would be curious what the questions are. And then additionally, and I'm going to look up to the sky to make sure like a risk management lightning bolt doesn't strike me down. But I would, there are asynchronous support, telehealth services out in the world. So psychoeducation sites, as you say, self-guided study, as you say, there are services that offer text-based and email-based. I don't know that we have the clinical validity data on all of that yet. So I want to be clear, I'm not endorsing it specifically for behavioral health, but it's interesting. It's a huge area of growth in the telehealth world, and it does exist. It's not what I do in my clinical practice, but it's out there. It's interesting. And if I explored with someone why they didn't want to do this and they were just steadfast, absolutely no, then like you, I would probably make them aware of other services, they could be using to receive hopefully the appropriate level of help.
And I guess I'd also follow up, Sarah, with the caveat that when we first started talking about this and presenting on telehealth, there were a number of our colleagues that were absolutely never going to do this. And they've come so far.
Yes, pre-pandemic, there were a lot fewer telehealth people than there are now. And this is not how I hoped we'd be democratized, but here we are. Okay. I've got another really good one. And there's actually 3 that were about this same. So I'm going to try to make an amalgam here. For clients who have left their home city and are away indefinitely, e.g. until the end of the year, or whether their work may require them to return in person or their family obligations may conclude, what are your thoughts about continuation of their care and versus transition of their care? This is one that I think is a really great question, because I think a lot of us are, just as you were saying, therapists are going one place, clients are going another place. We're trying to figure out the in-between. I would start off with the stock advice that you and I always give, which is, check are you practicing interjurisdictionally across state lines, for example, internationally, for example, check rules and regulations as they are defined by that state, by your home state where you're licensed, and then check that ASPPB website, which is on our resource slide, which will be coming around again in a moment. But check if there are any temporary orders facilitating interjurisdictional practice. But that's not really what this question is. This question is saying, okay, I'm aware of all that, but I don't know if they're coming back, and eventually we know these executive orders expire. And so folks may be in a circumstance wherein the executive order allowing them to practice into another state expires, their client's not, they're still there. What do they do for this person? And I'll tell you how I'm thinking about it. And Margot, I'm curious how you are. I'll say for me, I am practicing as long as 2 things. One, I'm checking with my client. What do they want? Are they saying, wow, I'm so relieved to be home. I'm near my parents. That's very helpful. I'm going to be here for a while. Then I'm going to have a conversation about, okay, well, should we start thinking about finding you care locally? Are they ready to go back to in-person care? what's the situation where they are? Is it opened back up? Is it locked down? What's the transmission rate where they are? If they're in the middle of nowhere and they've had one case in the whole state, I don't think there is a state like that, but let's pretend they're in outer space. And, in that circumstance, I'm going to be thinking more about transition. If they just don't know, if they just don't know and the executive order still allows it, then I'm probably, or I'm not practicing interjurisdictionally, then I'm probably going to continue care until such time that they have more clarity, or until such time as an executive order ends and I'm no longer legally able to practice where they are. I'm curious, Margot, how are you negotiating some of these themes?
Well, it's a really intriguing question. And a couple points come to my mind that are actually things that have run through my mind with even current clients. And that is, how are we doing just in terms of the clinical snapshot, right? Are they traveling and now have more stress or less stress now that they're back home, or back, indefinitely somewhere else? The other question that comes to my mind is really just kind of taking stock of what the situation is. And like you said, with expiring executive orders, we have a scenario where I live right on the border of North Dakota and Minnesota. We have a lot of clients that live in Minnesota and come over to North Dakota for care. It's across the river. That's where most of the providers are located in some of our communities. And Minnesota had an executive order that allowed us to do teletherapy into Minnesota for those patients, and it expired. So we can no longer do that. Now they are able to cross the border now, but that doesn't mean that they're comfortable coming to our office. And frankly, some of our offices aren't open. And so we really have a situation where there are clients kind of hanging out there in need and not able to actually get services. And so in those situations, it's really a call, not just to the board office to explain the circumstance, but also to the legislators who truly don't necessarily understand how some of these pieces are limiting for their constituents.
That's a great point, and I think an important sort of advocacy angle on all of this I hadn't considered. Well, in the interest of time, I'm going to move us along in our agenda. There are more great questions, and keep sending them in. We're going to come back to a couple more here. We had received a question previously, and I would summarize it sort of asking about how are we thinking about a mixed model of practice? Because for many of us, we went from being all in person to all telehealth, and now we're transitioning. Some of us are transitioning back to in person, some portion of the time, all the time. Some of us are transitioning part of the time back to in person and asking the question, well, what does my practice look like as a part telehealth practice? And I want to acknowledge there's no one right way to do this. But I guess these are some of the points of considerations I've been chewing on. I think there are these higher order considerations. Where do I live? What are my jurisdictional orders? Are we locked down? Are we opened up? What is the rate of transmission of coronavirus where I live? I think informs how risky a prospect it is to open back up. But moreover, what are some of my personal variables? How willing am I? I've had folks in consults with me in the last month or so say, no way, no day am I wearing a mask. I'm just not. For that person, I would probably have a recommendation of more telehealth than not, if not entirely. If they're not willing to do it and they're not willing to ask their clients to do it, I would be more concerned from a risk management standpoint for that person's well-being and for the client's well-being. I think I'm also interested in these same attitudes among our clients. I know some providers are surveying their clients, not formally, but like at the end of a session, like, do you want to come back into in-person? What are you willing to do? Are you willing to do a temperature check? Are you willing to wear a mask? How would that feel for you? And having some of these conversations. And thinking a little bit about what types of care transition to telehealth most easily. I think the ones I hear quite a bit are going to be the first ones to go back for a lot of practices are assessment cases, forensic work, working with pediatric clients. A lot of folks have said, boy, this has been tough. I've had colleagues talk a fair bit about they like telehealth, but those intakes, they really like to do them in person. I'm actually the same. I like to do my intakes in person, and that'll be one of the first things to come back for me. I will also be transitioning cases where there's any concern of domestic violence back early and often, once I can. So I think for me, I'm thinking about this, like which clients seem to do well in the modality. I've had clients say they love it. I have clients say they hate it, and that's going to factor largely into it. What is the relative clinical stability of my client's caseload? I'm probably going to transition the clients who are struggling to in-person sooner rather than later. They would be among the first that I would bring back to an in-person practice. Again, not that there's a data-driven reason. That's just my own way I like to practice and my own level of comfort, though we certainly manage emergencies remotely all the time. And I'd want to know, to what extent do I feel like the client's engaged? A lot of folks are talking about this feeling a bit stymied, feeling a bit plateaued with a client. Now that could be because all we talk about is COVID in some of the sessions. I don't know. But I think there's a lot to be learned, I think, from schools. A lot of us have children in schools, I know I do, and they are reopening. And I think there is this interesting model that they are offering where there is this mixed element that, there's a cohort, smaller cohorts are going some remote, some in person, and the idea is they are reducing risk by putting people in contact with fewer numbers of people, fewer hours of the day. And I think there's something to that. And there's something that we could potentially learn from that, because it's not an all or nothing thing. My risk is not the same if I sit with 3 people versus if I sit with 10 people in a day. So I think that there is this question of how do we want to mitigate this. And finally, I will mention, I've had a lot of folks ask about the feasibility of outdoor therapy. And years back, I think there was an issue of the Monitor, the American Psychological Association publication, that talked specifically about outdoor therapy and the specific informed consent considerations that we want to gather, but really saying that we can do outdoor therapy, we can do it well, but we need to think through, what that means for privacy and confidentiality. We need to make sure that our clients really understand that risk. And you need to make sure you don't live in Seattle, Washington, where it rains on you constantly, because it's just not going to work. But I have had folks call me and say, hey, I have an area, in my private office area, I've put up a big tent. I've got a space heater out there, and I'm going to see my clients there. And they have, set it up in a way that I genuinely think it's going to be private. They'll need to be thoughtful about that, and they'll need to explain it to their clients, but it's an interesting accommodation that I hadn't thought of previously.
That is interesting. I was actually kind of visualizing just walking for the therapy appointment time, and realizing, there's some potential here of, really using behavioral activation for some of these, clients where you're not just sitting maybe as well. Obviously, there's some consenting and informed process to that, but I think folks are starting to get creative, and that is a piece that is intriguing to me, as I think we're going to have to be creative throughout the next probably couple years in managing this.
I agree. We just got a live question that was related, and if it's okay, I'll go ahead and read it. It says, what if I was, as I open, there are a few clients I wouldn't be comfortable seeing because I know they are traveling or engaging in higher risk behavior. Can I cherry pick, who I see? And that's a great sort of ethics question. I'll give my opinion, and then Margot, I'd be curious what you think. I think yes, provided that we sort of set a standard, we're thoughtful, we make a policy, we set a standard, and we communicate it to everybody and capture their consent. So from my perspective, this would be, and I would encourage everybody to look at the Trust website. They have a lovely document that is a template for return to in-person care. I might consider adding an addendum that went through sort of my expectations. I would be inclined to disclose how I'm living in the pandemic without, talking too much about my personal information, but these are the rules I'm observing. I think it might be a reasonable conversation to say, I want to have a conversation about this. And I would just want to make sure the rules are the same for everyone. But I think if we could do that, it feels reasonable and fair to me from a contact regulation standpoint. I guess, what do you think, Margot?
Well, it's interesting. That is one of the things as North Dakota opened up that was very particular. There were very set requirements. So if you were going to be seen in a medical or service industry office, you had to do a temperature, you had to wear a mask, you had to disclose if you had traveled outside of the city within 14 days. And if you had, you couldn't be seen for services. You had to follow hand sanitizing procedures. Some of the requirements have been lifted in that, some have not. And so I think, like you're saying, if you identify what those requirements are, and that is across the board for everybody, maybe one of your requirements is that you're only in contact with 3 other people outside of your home, and they can't be travelers. So, I think as long as you set your office policy and have it documented and you're consistent with how you implement it, then no, you don't. I wouldn't be thinking that as cherry picking.
Yeah,
But ultimately, it does come down to, you are a service provider, and if you do not feel safe providing the service, you are not obligated to do that. You have an alternative approach for that, and you can manage how that is set up. And maybe those are either a cohort of folks that you may want to refer if they want to come back into the office, or you would just continue to see them in terms of a virtual contact.
Yes. I mean, I think it harkens to the question of how much do I want to be asking my clients to disclose, and how comfortable am I disclosing myself, and I think we just received a related question, actually, and I'll read it because I think it's a nice augment to this conversation. Would you advise a client to notify us if they develop the virus after a session, not necessarily from us? And do we need to isolate ourselves for 14 days? I will not, I'm not an infectious disease person, so I won't opine necessarily. I think that, well, I'll speak to the first part of the question. I would, and I would probably ask people to disclose to me, and would promise that I too would disclose. And again, this would be something I would write down. I would have a conversation. I would say that I would both ask to be disclosed and disclose myself, that if I did test positive and had contact within 14 days, that I would regard myself as obliged to tell that person for reasons of contact tracing. Unfortunately, I know this has become like a politicized thing, and some people don't want to do that. And that's the type of thing I'd probably, it's a good conversation to have before somebody gets the virus, not after, so it'd be the type of thing I would want to talk about in an informed consent context. And because we really do start getting into some boundaries. I've never asked so much about my clients' health behavior. I've never asked how often they wash their hands, unless it's in an OCD context. I've never asked some of these questions quite as much. I know we're getting toward our time. Margot, I'm sorry, I don't want to cut you off, but what do you think? What else would you add to this? And then maybe let's get back to our...
Well, I think to that point, it's a public health factor as well, that you may not have a decision. It may be made for you, that the public health department may require that disclosure be made. And so again, it's local jurisdiction, it's state jurisdiction, and your patient who, may test positive afterwards may not actually have a choice in disclosing that, yes, they were at that appointment. So absolutely, I think it is an important conversation to have if you're returning to the office.
Regarding isolation, I'd probably ask my medical doctor, what the avant-garde sort of recommendation is. But I would think there's a good chance we end up having to isolate. Okay. Well, we have a couple more topic areas, and I will hold forth and talk a little bit. We've had a few questions today, and we had questions submitted in the prior week about inpatient care and telehealth. This was something, I had in my career. Actually was implemented, interestingly, in the context, this is relevant, for infection control concerns. I worked at a very large hospital wherein there was a massive outbreak of C. diff, not so fun. And as a way to minimize contact between provider, patients, visitors, they really did any appointment that could be done remotely through telehealth was for a period of months. And so, this can help if there are ward restrictions or there's a restriction within the ward. If there are visiting restrictions, this can be one way. In the context of COVID, this obviously has relevance because I know people are being hospitalized. They're not permitted to have visitors, very limited opportunities for staff to come up. come and speak with them. So I think this idea of bedside consultation, bedside care through telehealth is a valid one. When I have seen it done these days, people have iPads and their iPhones. If the hospital has the resources, they're actually what they call carts. They're often made by a company called Tandberg or Polycom, where you wheel the cart in, and it's a very large screen. So there are different ways it can be done. I think that, it still requires a technician for the large scale equipment, and often for the iPads and things like that. You still have to have someone come in and set it up. So it's not like it's contactless. But as telemedicine, I think I am not aware of inpatient institutions using the totally user-driven versions, but there are totally, as we know, we're all using telehealth that just our user can set up. So the opportunity is there. I think most inpatient facilities are not using that. They're using other alternatives. The one thing I will just say that this is a tool that can offer support and companionship, particularly, and comfort during a period of time where people are receiving little, and people talk about it feeling cold, particularly in the context of inpatient. And that is where I've received that feedback, that people feel like the connection of just having someone come to that hospital and see a familiar face was valuable. But I think we're in this moment talking about times that it's not possible.
Mm-hmm. I do have a number of colleagues that have talked about their consultations to actually long-term care facilities. And while I don't think of them as inpatient psychiatric, they really are an inpatient kind of closed population at this point, because there is such limited ability for anybody to come into those environments. And so I think we really are in this space where even the hospitals are getting creative as to how we can, carry forth and have some mental health care delivered. And we have to go the extra mile over the video conferencing to really help folks who are in that more isolated atmosphere feel more warmth through what we're doing. And it is more work on our part, but it doesn't mean we can't do it. We just have to kind of spend the time and effort involved in that. And it's not the same, but we can sure make a difference that way.
Well said. Well, we've had a lot of folks ask us today and previously what platforms we use. And you and I always joke that, like, oh no, but if I answer the question, then next week it might be different. So I thought we'd offer this caveat that we could tell you what we've been using recently, not endorsing any product. The trust isn't endorsing the products that we're talking about. We're not necessarily endorsing the products we're talking about, but we could talk about some of the things that we've been using recently.
Yeah, sounds good.
Okay. Well, I'll rattle them off really quickly because it's a pretty short list. Yeah. These days, I use Simple Practice for my electronic medical record. I like it. It's very large in the space right now, so I imagine a lot of folks watching use that as well. There are other great EMRs out there that have integrated video. This just happens to be the one I use. They offer a video product for an additional $10 a month, and I'm a sport and pay for it. Then in addition, I like to have backup options. So I do have a Zoom PHI compliant. I have a telehealth Zoom product. It's a long story. It's very pricey. May not have it that long. And then I also use as my backup Doxy.me. And I also have VC. And those are the ones I'm using the most. Now we know we could also technically use Zoom, regular Zoom. We could technically use FaceTime. Some of these others, we've had this announcement from USDHHS saying we could. I personally don't. That's not the way I do it. I have historically used DocuSign to capture signatures, but now it is integrated into my EMR. So I just use the digital signature program in my EMR. I have historically used Tiger Connect, which is a snazzy texting messaging product. But these days it's integrated into my EMR. So I just use the secure messaging program that's in my EMR that functions very much like texting on my mobile device. Those are the products I'm using right now. What are you using?
Well, my list is slightly shorter and very similar. My practice uses Simple Practice, and when we pivoted to video conferencing, we added the $10 a month line, and I love it. It's super smooth. I've not had any difficulties aside from not being able to share a screen, share something like a document that I wanted to show. So I do end up showing a lot of my things in very bad creative art that I do, but it all works out. My backup is for video conferencing is doxy.me. So very similar. And I have not wanted to explore FaceTime and the freebie options most primarily because I don't want them having access to my personal FaceTime, email or text
Right.
account.
Right.
And because they can start the video conference
Right.
that way, and I prefer to have it be a one-way link.
Me too.
So,